Okay, why don't we get started? Welcome everybody to this month's teamwork group. We have, what happened to the slides? We have An and Sarah here from Tri Valley to talk to us. Uh, they're going to share what they're doing about great catches, building a culture and system that sustains near miss reporting. Without further ado, let's go ahead and pass it to them. Oh, also Kara, I'm sorry, I didn't also include you. I'll go ahead and pass it to that team, and we can go ahead and get started when they're done. If we have time, we'll go ahead and open it up to questions, comments, discussion with the group. So team,
Thank
go
you,
ahead and
Ryan.
take it away.
Thanks, Ryan, for inviting us. Thank you, everyone. And I actually have our slide deck, so I'll be sharing that. Um, Ryan, can you just please confirm if you're seeing the right one?
We see the notes. If you
Oh,
want to just
okay.
switch it. Yeah, that's good.
Yep. Okay, great. Um, Thank you, everyone. So we are from SHC Tri-Valley. So I have with me Sarah Griffith as well, and Kara Conley, who is our operations partner in SHC Tri-Valley from the nursing team. So today we are focusing on near-miss reporting and the near-miss culture. We would like to share with everyone as well the outcomes of a project that we did in 2024 with Vizient. So for most of us here, we probably already know what a near miss event is. So this is all talking about a patient safety event where the risk is present. However, because we are able to catch it, it didn't result to any accidents. So in this photo, we can see, for anyone outside of healthcare, this might be a good picture to reference to when trying to understand what a near miss situation or patient safety event is. So the unsafe condition, we can see that an individual is leaning over probably a dangerous zone, and in the unsafe act is trying to reach over to that hammer or handle, and in doing so almost fell or fell off, but not enough to really cause that big accident. And so in this case, the near miss situation or a great catch was a second individual catching that person before an accident occurs. So in healthcare, this is similar, but a little bit more maybe complex. So in SHC Tri-Valley, we follow the HPI classification of events or harm. So as we can see here, the near miss safety event is further defined as a presence of a deviation from generally accepted performance standards, but this deviation or medical error does not reach the patient because the error is caught by a detection barrier or by chance. Why is this important in healthcare? It is so very important because patient safety is not only really dealing with the aftermath of events, after there is harm already. So a big portion or a big principle in patient safety and improving patient safety is really proactive work, preventive measures, and really being proactive in our approach to preventing harm and improving patient safety. So in recognizing near misses and great catches, this is an opportunity for us to recognize timely and ahead of time those vulnerabilities in our systems and processes. However, we do have some issue with near miss reporting. We wouldn't know this near misses and great catches unless someone speaks about it. Or in the patient safety realm of things, if someone notifies patient safety or the appropriate leader that there is such an event. So in general, it is really underreported, underrecognized. Our patient safety organization, CHIPSO, in March of 2024, released a statement that since October of 2022, when they released or launched their CHIPSO data, which is a dashboard where members can see the trend of events that are being reported or submitted to CHIPSO, only 11% were near misses or great catches. They also said that 45% of all facilities who have reports submitted to CHIPSO have never reported a near miss event. They also shared that back in 2023, in a conference with the Agency for Healthcare Research and Quality Conference, that the agency shared that there is data suggesting that near miss events should really comprise approximately 44% of our total volume of incident reports for patient safety. So we ask ourselves why there is underreporting. So there is a lot of reasons outlined in the literature, and some of them I have here. One, it is still a voluntary reporting system that we use, and even CHIPSO is a voluntary reporting system. So the idea is that because it is voluntary, a good number of these events are not being reported or submitted to the appropriate channels. There is also a culture component and a psychological safety component where individuals might feel fear or be fearful of a potential blame or retribution. So the just culture principles come into play there. There is also lack of awareness of what constitutes a near miss and a failure to understand why it is important to mention it, to talk about it, to report it. There's also time constraints. So this time is a very limited resource, very finite for us in healthcare, a very busy work environment. And so there's not much time to put in a safe report. In addition, the uh, user friendliness of a reporting system also play a role. Given that we are very busy, the idea is that the system that we use should be very easy to use and simple. So in 2023, we had an opportunity to participate in a collaborative hosted by Vizient that is targeted towards high reliability practices. And so our team from Tri-Valley joined that collaborative, and we focused on near miss reporting and the intent to increase near miss reporting in SHC Tri-Valley. We partnered with 2 West, which is a patient care department, and Sarah, my colleague here, is actually a leader of that department for that med search unit, I mean. And so we have chosen to partner with them and leverage their team for a pilot. So we looked at the data initially for a full fiscal year prior to the collaborative from September 2022 through August 2023. And we can see here for the 2 West department, there is only 10% reported near miss events for that whole fiscal year. So we agreed on a goal that by December 31st of that same year that we started the project, we will commit to increasing the number of near miss or great catches in the 2 West department to 2.75 safe reports per month. So for those of us here who are not very familiar with our incident reporting, Stanford Health Care uses the MIDAS system for patient safety incident reporting, and SAFE is specifically referring to the actual patient safety event report. This project also gave us the opportunity to align with our FY24 operational plan of increasing near miss reporting by 25% by the following year, August 31st of 2024. So we dived in and did an analysis of why there is underreporting in our pilot unit, and we found some similarities with what is already in the literature, culture, knowledge and awareness, the workload, the system that we are using, um, people, and also the time of event occurrence. There are less events happening during the night shift, and thus there might be less reports of near misses during that time. But we also found out that closed loop plays a very important role in promoting and encouraging a culture of reporting of near misses. So our key drivers for change that we've identified are as follows. There must be an understanding of the importance of reporting a near miss. There should be awareness and understanding as well of the other levels of harm besides near miss. There should be a protected time to submit an incident report. The incident reporting system should be user-friendly, and there needs to be timely follow-up and closed loop, especially with the submitter of the incident report. On this series of slides, we will see the interventions that we have done to address and support these key drivers. For the level of understanding and awareness and knowledge, we leveraged and used everything that we can that is available to us to really spread a word, including huddle times, newsletters. We've developed additional teaching materials, one-point lessons. We've included and introduced this topic to our new employee orientation and has embedded it as a standard agenda for the new employee orientation hospital-wide. We've also added that to the RN onboarding manual and has been part of the department onboarding for our employees. We've developed visual tools, including laminated copies of the harm scale for the visuals. Um, we were looking for additional fun, catchy visual tools. And then we also incorporated teaching this in the Teen Steps class that is required and is a standard part of the hospital-wide new employee orientation. So there are several interventions and actions that we did to really address the opportunity in being aware of what this is and really understanding what this is in terms of patient safety.
And there's a question in the chat. Can we speak more to the protected time and how you achieve that? I can speak to it if you want me to.
Thank you, Sarah.
Yeah, of
Perfect.
course, no problem. So for the protected time, it's a very tricky protected time situation. So we had, sorry. sorry. So we have where if it's at the end of your shift and you have to, an opportunity where we need to submit a MIDAS report, you have that time to submit it, even if it's going to put you in, 5 minutes of overtime. We really want to make sure that the opportunities are submitted to us so that we can be aware of the situation and look at it and make sure that we're doing everything to really make sure that these situations are looked at, and that if we do have an opportunity, we grow from it and we learn and we fix the situation. So we just allowed the team to be aware, like, we know that we're very strict about overtime, but in these situations, these are exceptions to this situation. Welcome.
Thank you, Sarah.
Of course.
And I think this is what Sarah has just pointed out. So we'll move on to the next slide. Regarding our incident reporting system, which is MIDAS currently. We have system administrators for the MIDAS, and there is a MIDAS governance team where we can channel some of the feedback that we're receiving from end users of the system, suggestions on how it can be better. That is channeled to us. We immediately share that with our MIDAS system administrators and our governance committee members. During this collaborative as well, the MIDAS system, although this is a totally separate project, launched an updated version of MIDAS where now we can access the submission form when we are in the patient's chart. And so hopefully that has really proven helpful as far as having a limited time to find the link and where to go. And so we really appreciate that update. And so now there are two ways that folks can access the incident reporting. One is when they are in Epic in the patient's chart in the correct encounter, and also accessing it through our intranet portal. Timely follow-up and closed loop with submitters of incident report. Our 2West team, where we did a pilot, partnered and learned from the DI team, which is our diagnostic imaging team in SHC Tri-Valley, who we know has really put in place a practice on closed loop with their team members regarding events. And so they joined a meeting where that was happening and brought back some of the learnings that they observed back to their team in 2West. It is still an opportunity, though, for us to ensure that there is timely follow-up and closed loop, something that we always emphasize and remind our team in SHC Tri-Valley whenever there is an opportunity. So after all that we did, we were really happy with our results. Our project goal was really to increase to 2.75 safes a month, and we surpassed that target almost immediately following the start of our intervention, starting in September of 2023, and we've sustained the increase into the next quarters. Referring back to our operational plan goal of increasing near-miss reporting to 25%, we have also surpassed that goal by achieving a 177% increase in our near-miss reporting by July of 2024. So how are we doing now? We are still working on our interventions and continuing our efforts to sustain that improvement. What we have seen worked well for us is really the approach that we did almost immediately is to engage everybody that we can. So the engagement happened at all levels, starting from our local areas, local departments, and local teams through our executive leadership team and board of directors, leveraging safety huddles, monthly leadership meetings, monthly patient safety committee meetings, monthly joint quality medical staff committee meetings. We also incorporate activities related to fun activities focused on near miss reporting and patient safety during the annual Patient Safety Awareness Week. Again, it has been included in our FY24 operational plan, continuing on that goal in our FY26 operational plan to increase near miss reporting now up to 30% for this year.
And I think one thing we forgot to add, Anne, in that slide is
Yes.
we also brought it to our staff meetings like consistently each time we had staff meetings to really make sure that the teams didn't forget about the submitting the MIDASes and really bringing back some of the opportunities that were found in the MIDASes to the staff meetings as well.
Thank you, Sarah. We are really fortunate of our partnerships, and especially with our MedSurg team who's really taken ownership of this. So thank you so much, Sarah, and to your team. We performed and continuing our comprehensive education and training with our new employee hospital orientation and team steps training, department onboarding, every 6-month interval providing refreshers to our medical staff, our unit-based medical directors and dyads, and our MDRN committees. We are continually looking for opportunities to improve our incident reporting system, such that one day it becomes a very user-friendly system and simple to use and streamlined. We have also developed and launched and published our patient safety dashboard, where information on incident reporting and near misses are visible to our leaders. And so we use that as well when we present or have a discussion around near miss in our incident reports at the various meetings.
And there was actually a question about this.
Yes.
What were some of the specific recommendations to make MIDASes more user-friendly besides adding MIDAS submissions featured in Epic? So I agree with what Anne said, and it is a struggle. It's something that we all always are looking for opportunities to make MIDAS a little bit user-friendly. And it's just mainly just having those conversations and assisting the team in submitting those MIDASes when the opportunity. So we do have, you'll hear later on, like safety champions. We kind of use our charge nurses to be the people that we support to help, primary nurses or others to submit MIDASes so that they can get into the system, or they could always reach out to the managers for that support. But it is, I feel like it got a lot easier with Epic, but there is some opportunities still. I feel like we did submit, we did like provide posters, like Anne said, to choose, like if it's an unsafe condition, if it's a near miss or a safety event, a serious event. We did provide those to the team so that they knew what to put. But as leaders, we did follow up and change it depending upon what the MIDAS was, if we felt it needed to be changed because they were unsure of what to do. So
Sarah, I wanted just to add a little bit. I'm seeing some of the questions. My name is Alicia. I'm the manager of that department where we did this pilot. And first of all, I'm really grateful to all the team members because they just really embraced this this project. But going back to some of the questions that people have put on here, it was really a culture change for us because when we began this, really the teams were under the impression that the manager or the charge nurse or the assistant manager was responsible for putting in these safety events or near miss events. So it took, a few months to really engage the staff in doing the work. And, we spent a lot of time one-on-one showing them how to do this. And then also sharing these submissions at huddles, at staff meetings, just so that we can learn from them. So really, when we talk about like just culture, really that is what we embrace. Like if someone made a mistake or found a near miss, there was no, the blame game. That is just something that we just don't do here. We take them as opportunities to learn. And I'm learning every time somebody, brings something up. Today, there was an issue with the percentage of sodium in fluids, and I learned something about the protocol that we're going to share at Huddle because it's something that we don't see very often. We also close a loop with the staff members who are submitted or involved in those safe reviews, because if we don't close the loop and they just think that we're not taking it seriously, the submission, or we're not doing anything with the information. So really getting back to those people and letting them know that it's important and we are following up. And then just the last thing with the physicians, we do include the unit-based medical director on many of these as we refer them to those physicians. So they on their end can maybe provide some feedback, some education, or maybe even educate some of their team members. So it really takes everybody. It takes the village to just enhance the workarounds like submissions, because the staff do get a little reluctant sometimes, and we just have to remember that someone's going to be better because they did that little extra step.
Thank you, Alicia. That's beautiful. Any questions for Alicia or Sarah? Ryan, should we just go through the questions for now?
I think that would be great, and then open it up to other questions if
All
you're done
right.
formal presentation. Yeah.
Yes. Regarding user testing of the friendliness of the system, actually, this is a great recommendation suggestion here, something that I can bring back to our Midas administrator to ensure that as they look into opportunities and future improvements in the system, that they include users to test the environment. Yes, definitely. And I believe that they have in their previous projects. Right, so the next one, impacts. But as far as impacts, is this referring to impacts in the clinical, or impact to just to the improvement work? Sorry, Kylie, Kylie.
While we're waiting on that one, maybe we could get back to that.
Yes,
And looks like Jake has his hand raised.
yes. Go ahead, Jake.
Hey, Anne. Hey, team. Thanks for this presentation. This is
Hi,
really great.
Jake.
I noticed even in this presentation, every time we say near miss, we say good catch. We use them interchangeably. Thinking about the culture of doing this, I've seen some institutions are not even using near miss anymore. They just use good catch. I hear both still across Stanford. Do you think there's any intentionality with that?
Yes, and thank you, Jake, because you reminded me of something that I wanted to point out and then I didn't. So in this slide, when we were developing our goal, this is where I think that culture change that Alicia was talking about really honed in into our team, into our project team. We discussed and talked about this very verbiage extensively, that near miss and great catch, which one do we use? We were even thinking how to title our project, and we decided that yes, we would like to adapt the positive verbiage of a great catch. And in reality, when we are recognizing and acknowledging folks who have submitted a really great catch, the name of that recognition or award or presentation is Great Catch. In our patient safety committee meetings that are done monthly, we have a standing agenda in that committee meeting for a Great Catch recognition that comes from the safe reports that we get. And so we invite our leaders to recognize that event and the individuals that are involved in that great catch. And the title of the slides is a great catch. So I believe that through this project, that got put into the very forefront, that, you know, great catch has a more positive, I guess, impact to folks instead of a near miss. It could be highlighting a miss when in fact it's a positive catch. So yes, it was part of all of these culture change and culture shift, and I totally agree with you. That the outcomes wouldn't be possible without that. It's a huge driver.
Yeah, and, I, and
um
I'm not and I'm not stating whether I prefer one or the other. I've just noticed that it depends on who I'm with. Some people say, "Oh, Jake, we call those great catches," or "No, hey, we call those near misses." And as we try to make a culture change, it is helpful to have a shared terminology that we know we're talking about the same thing.
Hi, Anne. This is
yes.
Suki, if you don't mind my jumping in
Hi,
here.
Suki, of course.
Yeah, yeah. So, Jake, this is a really great question. And there's actually been research on this. And so, Joe Carlucci and I had done some research and read and reviewed that near miss actually inhibits people to actually want to do a report because it's like, who wants to show up and say, hey, I nearly missed something? But a great catch actually influences your brain to say, oh, okay, it was something positive that came out of this. So, just some heads up on that. So thank you so much again for engaging in this conversation.
Thank you, Suki. Suki is actually part of our project team. So thank you, Suki. Just a follow up to Jake, because this is a very important topic, and maybe we can talk about it all day, the culture and its impact to patient safety. I would like to think of this as well, the journey. Just overall for organizations, for the country, just for the rest of the world, moving from a culture before when everything was seen as maybe punitive, um, maybe from a negative light. And so I think that near miss has been put in place, maybe before our time in our career, in our roles here in patient safety. But I think as we look to the future, how patient safety is evolving just in the society as a whole, that eventually this will be more widely used and more seen as a positive catch. Um, everyone here has, most of us has probably read about, the journey and the evolution of patient safety. And so I think that this is great learning, and it doesn't happen, in a year. And I think that this is just all part of that march towards a better patient safety culture.
And I wonder if it might be worth, if you'd be okay with me calling out Juliet. I like what she had to say. I'm curious if she'd be willing to uh, speak in more detail about it.
Yeah, happy to. Hi, everyone. I think I was actually really, I really liked the conversation though that Suki brought forward. My call out is I think getting clear on did we get lucky with this near miss? And did we have maybe a planned barrier catch where a team member had a great catch from maybe going above and beyond in terms of their critical thinking, attention to detail, or maybe a system or process that caught something? Barcode med administration comes to mind. I scanned it. I realized I was about to give the wrong medication. That's sort of a planned barrier catch, but a great one that we want to hear to say, oh, we almost gave the wrong med. What happened there? And so glad that our technology in place caught that. Versus, let's use that same scenario where a patient speaks up as we're about to give them the incorrect med and they say, hey, I received a different number of tablets yesterday. Are you sure that's the right dose? Now, that's sort of an unplanned barrier catch, right? We should be involving patients in their care, so in that way, it's great. But we went through all of our processes and almost gave the patient a wrong dose. So there's some distinction there. But I think from the language perspective, I can appreciate sort of that call out of how a great catch from a team member perspective, that could still resonate for them as a great catch, though it's an unplanned barrier catch in our system. So good food for thought, though, in this conversation. Thank you.
Thanks for that perspective, Juliet. I think we have a lot of questions, and I'm looking at our moderator. I still have a few slides, but would love to get to all the questions posted here as well. Jake, any suggestions? Oh, I mean, Ryan.
Yeah, why don't you go ahead and finish your slides? We
Okay.
can,
I
the
think there's
questions.
just a couple.
Yeah,
Yeah,
go ahead.
thank you. I think this slide is really so important since we started talking about the culture. So acknowledgement and recognition. We bring forward great catches in our quarterly rewards and recognition. Again, Patient Safety Awareness Week and any activities where it's focused on patient safety. Various committees like our medication safety committee have a standing agenda as well in their monthly meetings on great catches where they solicit nominations from leaders on great catches and select the best or maybe the most something that's calling out to something really important. And so this has really been embedded in a lot of our practices. Another way that we are soliciting recognition and promoting and enabling recognition of near misses is embedded in our debriefing process where well, when this big events like a massive transfusion protocol happens, the team debriefs about that event to talk about what went well and what can be improved. And we have developed a tool for them to use. And in that tool is a question, are there any shout outs that you wanted to give to any of your team members during this massive transfusion protocol event that you responded to? And so really trying to encourage people and really develop and cultivate a positive environment for our people. What is in the future for us, since we've done a lot of things already, and of course there are remaining opportunities. What is next for FY26? Our organization has committed to training 95% of our leaders on just culture training. Again, this is emphasizing the role of culture, of a positive, fair culture in encouraging folks to speak up and to report as part of our learning culture. Before I end, I really just wanted to thank our collaborative partners and participants that are on this slide. So we wouldn't be able to do any of these efforts and initiatives without the partnership from everyone in the SHC Tri-Valley team. Thank you.
Outstanding. Well, thank you very much, team, for presenting and being willing to share your good work and being able to stimulate such good conversation. There's been a number of people participating as well as being on the chat. So thank you all for your time. It's about 5 minutes to 1 o'clock. So I'm going to say thank you to everyone and go ahead and close out this call. We look forward to connecting with you more. I'll post this on our website so that you can have the recording there, as well as try to make our next session and connect with us. So thank you very much. Appreciate
Thanks,
your time. Have a
everyone.
great day.
Thank you.
Thank you.